हाँ। हुँ, हुँ। मतलब?
Can I please check whether the sharing of my slides?
Yes, sir. Yes, sir. Please, sir. Please.
Pratik, is it visible?
Yes, sir. Yes, sir. Visible and audible, sir. Perfectly.
Great. Then I'll stop over here.
Sir, your video is off, huh? Vishal sir.
Yes, sir.
Yeah, I kept it off. You want me to turn it on?
No, it's okay, sir. I think as per your convenience, you make it. Just inform me.
Yeah, I'll do that.
Thank you, sir.
You can let me know whenever I have to go on. Okay.
Good evening, Dr. Vishal.
Good evening, Prasant, sir. Good evening.
Sir, good evening. How are you, sir?
Good evening. I'm good. I'm good. How are you?
मैं फोन करता हूँ सर इसके लिए.
Good evening, everybody. Today we are going to start the first session of our upcoming this pediatric neuromuscular update, and few participants have joined till now. Only 34. We are waiting for participants to join, and then our division head, Dr. Inder Kumar Sarawat sir, will introduce the chairperson and the speakers soon. Thank you, everybody.
Yeah, it's perfect in that, sir. Now it is okay.
Good evening, all. Myself, Dr. Inder Kumar Serawat, on behalf, and along with Dr. Pratik Kumar Panda, on behalf of Pediatric Neurology Division and Department of Pediatrics, All India Institute of All India AIMS Rishikesh, welcome you all on board for the 7-day long pediatric neuromuscular disease update. First, to begin with, we would like to thank our Honorable Director, Sir Padma Shri, Professor Ravikant, for giving his blessings. We also thankful to the to Professor Manoj Gupta, sir, and Professor Nonit Kumar Bhatt, sir, head of the Department of the Pediatrics, for their blessings and support. We would also like to extend our heartfelt thanks to all the dignitaries in the Scientific Advisory Committee and all the eminent speakers for accepting our invitation to be the part of this program. At the end of this 1-week-long program, we hope that this scientific session by all the excellent speakers will make you understand and generate interest about the childhood neuromuscular disorders. We finally very thankful to all the participants for showing their interest in this subject. We hope that you all will have a great academic week. So first, the today's session will be chaired by Professor Sriparna Basu, ma'am. Ma'am is the professor and head of the Department of Neonatology, and convener of the DM Neonatology program. She is the Dean, Corporate Social Responsibility, All India Institute of Medical Sciences, Rishikesh. Ma'am has more than 150 publications in various national and international journals in her credit. Now it's over to you, ma'am.
Thank you, Dr. Inder. Very good evening and warm welcome to AIMS Rishikesh. I'm so happy that Division of Pediatric Neurology, Department of Pediatrics, AIMS Rishikesh is conducting this gala event, a series of webinars on pediatric neuromuscular disease updates. And we have a galaxy of eminent speakers with us today. To start with, we will be dealing with congenital myopathies, and our speakers are Professor Vishal Sondhi and Dr. Prashant Johari. So let me introduce Professor Vishal Sondhi. He has done his DM from AIMS New Delhi, and he is currently heading pediatric neurology services in AFMC Pune. He has over 50 publications in his credit, and his area of research interest is diagnosis and treatment of neuromuscular diseases in children, and he has published quite a few papers on this. And I request the audience not to be just mute participants. Please be interactive and make the session lively. Over to you, sir. Professor Sondhi.
Thank you, ma'am. And thank you, Dr. Inder and Dr. Prateek for this opportunity. I'll just start sharing my screen. And
Vishal sir, your video is once again off. If you wish to open, you can open it.
I'm okay with this if the
Okay,
audience
fine.
is
That's
okay.
okay. Fine, sir.
Yeah.
Fine, sir.
So, the topic that has been given to me is diagnosis of congenital myopathy. It was actually given as congenital myopathy, but I'm going to restrict it to diagnosis of congenital myopathies. And I have voluntarily added this part that in the era of next generation sequencing, and try to justify this as we go along. So this is the diagnostic chart that we have followed traditionally, that the patient comes to us. Since it's a neuromuscular symposium, let's start with a neuromuscular example of a child, a floppy infant comes to us who has global developmental delay. We go through the clinical features, we go through the family history, and we advise ancillary testing such as CPK, electrophysiology, plus minus MRI. A muscle biopsy is done, and the muscle biopsy is studied for the presence or absence of dystrophic features. And thereafter, the protein expression is studied in the muscle biopsy. Western blot is done, IHC is done, and the quantification of protein loss is done. Protein abnormalities, the structural abnormalities are studied. And then the candidate genes are identified, and the sequencing of these candidate genes is done or was done. Now the problem with this kind of a diagnostic chart was that there is so much of genetic heterogeneity that it was difficult to pinpoint which genes to sequence. By genetic heterogeneity, we mean that the same disorder can be caused by multiple different genes. So a lot of times, the PhD students and the other scientists, they would go on sequentially sequencing the genes, and that used to turn out to time-consuming and costly at the same time. Now the other end, or the futuristic or the modern diagnostic chart, is where a patient comes, and this is not a fictitious one. This happens at least in my center. It happens quite a lot of time. The patient comes and somebody has turned on. Okay. So the patient comes and a good clinician, maximum he or she takes the family history and orders the next generation sequencing. It has become so cheap and so readily available that all the intermediate parts are missed, the clinical features and the ancillary testing and nearly everything. Now, the problem is that with the next generation sequencing, these patients finally land up with us with so many different kind of variants, and then we have to do a reverse phenotyping, and we have to make sense of what has been detected and which particular gene is causing the disease. And in some scenarios, next generation sequencing is possibly the wrong test to be ordered because at times it doesn't cover the SMN gene, it doesn't cover the repeats. So, as we go along, we will try to make sense that what is the appropriate diagnostic chart, and I think that this is possibly the essence of this entire seminar. So actually, I want to title my talk like this on Star Wars, that the clinicians strike back, and the whole of my emphasis over the next half an hour or so will be to drive home the point that phenotype has to be studied, and it is the phenotype which has to be matched to genotype and not the other way around. So whenever we say congenital myopathies, now this is the whole spectrum of congenital myopathies. This particular kid over here possibly never um, uh, never learned to hold the head also, and was completely bedbound for whatever little time he survived for less than a year, had X-linked tubulomyopathy. This one's learned to sit, but always needed truncal support and needed support of the head. This one over here is characteristically myopathic face, is long face with the jaw drooping down. This one had scoliosis, was able to walk, but used to walk with difficulty. This was a pair of siblings who used to walk, but had severe bulbar weakness and used to have severe recurrent episodes of respiratory tract infections. And this is an image from internet, and this particular guy has myopathy but is able to cycle. So the spectrum is completely wide, ranging from a kid who will never achieve any of the gross motor milestones to a person who's even able to cycle. So, as I said, the thrust will be on the clinical spectrum. So, whenever we deal with a child whenever we see a child with hypotonia, the first step is always to differentiate whether it's a central hypotonia or a peripheral hypotonia. And by this, we mean that firstly we have to find that what are the features which suggest a central cause. Now, if the kid who has come to us has impaired alertness, has seizures or altered sensorium, the feeding and sucking is poor, and there's an abnormal head size, micro or macrocephaly, has dysmorphism, is floppy strong. Now, by floppy strong, I mean that the kid has hypotonia, but the strength is more or less normal, and the reflexes are either normal or they are brisk. Then we think that most probably the child has got a central cause. On the contrary, features which suggest a neuromuscular cause is an alert baby who's not moving, is weak and floppy, that is hypotonia with weakness, has depressed or absent reflexes, or has specific findings on examination in the form of fasciculations of myotonia. Out of these list of causes, the two features which most of us find most useful to differentiate between these two include the strength and the reflexes. Now, by strength, I mean that these kids, those who have got neuromuscular weakness, are not able to move or are not able to lift their legs off the beds. A common question which I usually end up asking is that when the kid is lying down on the bed, is he able to push down the bed sheet just by the movement of his legs? If he has never done that, we start thinking of a neuromuscular cause of weakness. And the next thing is that that we look at is the reflexes, and reflexes are the next most useful discriminator. And if I can find the reflexes, I'm more or less certain that possibly we are not dealing with the element cause of weakness. Unless and until it's a neuromuscular junction, we are possibly not dealing, at least not with myopathy or neuropathy or Ehlers-Danlos disease. I am sorry, but there is, yeah. So the next step is, once we have delineated whether it's a central or peripheral hypotonia, the entire workshop is on peripheral hypotonia, so we'll go down to that, is which anatomical part is involved, whether it's anterior horn cell, nerve, neuromuscular junction, or muscle. I'm not going into details of this, but the neuromuscular disorders which can present in infancy are spinal muscular atrophy, hypomyelinating neuropathy, at the neuromuscular junction level, neonatal myasthenia and congenital myasthenia syndromes, and at the level of muscle, it can be myopathy, muscular dystrophy, or myotonic dystrophy. Why I'm telling the entire gambit of it is because all these figure out as a differential diagnosis when we talk of congenital myopathy. So before we go any further into myopathy, I would like to spend a little bit of time over here on the structure of the muscle, then a little bit about differentiation with congenital muscular dystrophy, and then we'll talk about congenital myopathy. So this entire thing is the belly of the muscle, which is enclosed within the connective tissue called epimysium, and within this muscle belly are these fascicles, which are like group of muscle fibers, and each of the fascicle is surrounded by perimysium, and within the fascicles is the connective tissue called endomysium. And within these fascicles are each of these circular structures, which we can see are actually the muscle cell. Now, since the muscle cell is more longer than broader, it is called as a fiber. And each of these muscle fibers is surrounded by a cell membrane, which is called as a sarcolemma. And within these muscle fibers are other numerous small structures called myofibrils. There are multiple nuclei which are present towards the periphery of these muscle fibers. And the cytoplasm of these fibers is called as sarcoplasm. So each of these muscle fibers has a covering called sarcolemma. Within it is sarcoplasm and myofibrils and the nuclei. And these striated muscles are usually multinucleated cells. So when we look at the structure of the muscle under a microscope, this is how it looks like. And this is important to understand the difference between dystrophies and myopathies. Now, if we focus over here, this green line these two green lines suggest the sarcolemmal membrane of the muscle. That is the cell membrane of the muscle. This end is the nucleus. This is the sarcolemma, and this is the extracellular matrix, and this within it is the sarcomeric protein. And over here you can see the cartoon showing the showing different parts of the muscle membrane. So if there is any problem with this membrane, which may be in the form of the protein in this membrane, or just the supporting protein on the inner side of the membrane, or in the extracellular matrix, this membrane becomes dysfunctional. It becomes more leaky than normal. As a result of which there is an imbalance of the calcium influx and efflux which takes place. As a result of which these cells, this muscle cells, undergoes atrophy, it undergoes necrosis. Part of it, some of the cells may get regenerated, but rest of them will get replaced by fibrous tissue. So as and when there is a leakiness of these muscle membranes of the sarcolemma, resulting in necrosis of the cells, is called as muscle dystrophy. And because there is leakiness of the membrane, it also manifests with elevated CPK. But whenever there is problem with this actual contractile unit of the muscle, that is the sarcomere, the proteins which are making the sarcomere, that is congenital myopathy. So the membrane stays intact, as a result of which the CPK doesn't increase. The structure of the muscle grossly will look. When you look at it microscopically, there will be elements of the muscles which will be missing. So that is the microscopic differentiation between muscle dystrophies and congenital myopathies. A little bit about congenital muscular dystrophy, because it will be taken up in detail later on. As with all congenital myopathies, congenital muscular dystrophies, spinal muscular dystrophies, everything, the hallmark of this is hypotonia and weakness. So every peripheral weakness, I'll be stressing it again and again, there is hypotonia and weakness. And the common hallmarks of congenital muscular dystrophy is that there are contractures, the spine may be rigid, there may be scoliosis, they may have distal laxity, especially with collagen 6 disorders, and some of them, such as dystroglycanopathies, may have brain involvement. But an important distinction, which we'll see later on with congenital myopathy, the differentiation between muscular dystrophy and congenital myopathies, is the facial and bulbar muscles are often spared with congenital muscular dystrophy. And these children with congenital muscular dystrophy have a progressive deterioration over time, as and when more and more muscles undergo atrophy, the muscle mass will decrease, the power of the muscle will decrease, the CPK will rise, and finally the morbidity is associated with respiratory involvement. And if we do the muscle biopsy, it will have the dystrophic changes evident on muscle biopsy. Now, in contrast to muscle dystrophy, in myopathies, as I said earlier, also the sarcolemma is intact, so the CPK does not rise. It is the sarcomeric proteins, the actin, tropomyosin, and rest of the things which get affected, as a result of which the power of the muscle or the functioning of the muscle gets affected. So the clinical clues when we are thinking of congenital myopathy is that it has a congenital onset, it has childhood onset. Hypotonia and weakness are present in all of them. The rest of the features are that there is muscle wasting, the reflexes may be diminished or absent, but the facial involvement is quite common in them. And by face, we mean many of them have myopathic faces, which means that there is temporal hollowing, there's a long face, there's a high arch palate. But one of the key features in most of the children with myopathy or facial involvement is that the lower part of face is involved out of proportion to the upper part of the face. By this, I mean that the jaw usually ends up dropping much more than they have ptosis. So the jaw drop is often out of proportion to the eye drop in many of these patients. Intelligence is normal, CPK is almost always normal, and they are usually non-progressive as compared to congenital muscular dystrophy, which are progressive in nature. Other clinical clues are, like we said, in CMD, contractures are an important feature, but in congenital myopathies, contractures are usually not seen. There are certain exceptions to this rule. We will see them a bit later, but contractures are usually not prominent except in ankles. Joint hypermobility is not as much as we see with collagen 6 related CMDs, but some amount of joint hypermobility may be there. But finally, the most helpful signs in differentiating congenital myopathies with CMD and congenital myopathies with each other is the presence of facial weakness, ophthalmoplegia, axial involvement, and what is the family history. And morbidity finally is dependent upon the bulbar weakness and its associated aspiration, scoliosis, and the respiratory insufficiency. And in some of them, contractures involving the spine and involving the ankle may limit their ambulation. And again, to reiterate, the phenotype which is suggestive of congenital myopathy is hypotonia, weakness, hyporeflexia with reduced muscle bulk and relative absence of contractures. And the next helpful signs are the presence of facial weakness, myopathic face, long face, temporal hollowing, and weakness in lower part of face more prominent than the ptosis, a high arched palate, bulbar weakness, ophthalmoplegia with or without ptosis. Axial involvement. By axial involvement, I mean involvement of the neck flexors and extensors, or the involvement of the spinal muscles more than the involvement of peripheral muscles. These are the things which will help us differentiate congenital myopathy from congenital muscular dystrophy and different types of congenital myopathies from one another. So congenital myopathies classically have been differentiated or have been named based on their morphology, on their pathological appearance under a microscope. So classically, they have been described as central core, limbalene, multimini core, and central nuclear. What it means is, as we can see in the central core myopathy, it is the central part of the muscle where mitochondria are supposed to be present. So they are devoid of mitochondria, as a result of which, when they stay in that entire part where mitochondria should have been present, it looks just completely empty. There's a big void which is created in the central part. So there's a central core of void which is created. So central core myopathy. If these voids are small and scattered all over the muscle, it is called as a small mini cores, multiple mini cores are present. Namely, myopathy is, again, under a microscope, it looks as if there's a small worm-like inclusion which is present within the muscle. And central nuclear is the nucleus, as we saw in the beginning of the presentation, the nucleus is supposed to be present in the periphery of the muscle cell. If it is present in the center of the muscle cell, then we call it as a central nuclear congenital myopathy. So currently, the congenital myopathies have been classified morphologically into these subtypes: myopathies with cores, myopathies with central nuclei, myopathies with protein accumulation, and myopathies with fiber size disproportion. Now, those with core are actually the ones which are devoid of mitochondria. If it is in the center, it is central core disease. If there are multiple small voids, it's a multi-mini core disease. If the nuclei are present in the center of the muscles, then it is either a central nuclear myopathy or a myotubular myopathy. If the inclusion bodies, then depending on the type of inclusions which are present within the muscle, it can be a hyaline body disease, it can be a cap disease, or it can be limmaline myopathy. And if there's a disproportion between the fiber sizes, especially if the type 1 is less than 12 to 15% of the type 2 size, then it is congenital fiber size disproportion. So this is broadly the morphological classification. But how does this morphology fit in with the genetics that we have been like flooded with? Now there can be nothing worse in a talk than presenting such an intimidating table. Now there is no need for anybody to remember this table. It's humanly impossible to remember this table, and this table is not complete in any sense. There are a couple of messages which I want to give in this table. This table is basically illustrative, and I want to illustrate 2 or 3 important things in this. Now, the first thing is that congenital myopathies are genetically heterogeneous. Now, this means that limmaline myopathy can be caused by about 10 different types of genes. About 10 have been listed over here, but there are about 23 or maybe more than that genes which can lead to limmaline myopathy. Similarly with multi-mini core disease, similarly with fiber type disproportion. So congenital myopathies are genetically heterogeneous. Hence, all the more reason that you have to identify the phenotype before we venture ahead. And the second important message is that the same gene can give rise to multiple pathological pictures. If you look over here, the alpha tropomyosin can give rise to limmaline myopathy as well as congenital fiber type disproportion as well as multi-mini core disease. Ryanidine receptor mutation can give rise to central core disease, multiple mini core disease, and even to core rod myopathy. So the one particular pathological picture can be caused by the multiple genes, and the same gene can give rise to multiple pathological pictures. Both ways it works. So the general notion one gene is equal to one disease does not hold true when it comes to congenital myopathy. So this is one of the most important messages from this table. So what we need to do is, again, we decided it's a peripheral hypotonia. It involves the muscle. Within the muscle, we said, oh, it doesn't look like muscular dystrophy. The kid doesn't have contractures as much, and there's a loss of muscle bulk, and the CPK is normal. The mother does not have weakness. The mother does not have myotonias, and then the next step is that, okay, it is a myopathy. Then within the myopathy, what particular phenotype does the child fit in? So this is the final step which we have to reach whenever we are thinking of congenital myopathy. So again, to reiterate, now since this is an important part, I'm reiterating it again and again, that feature suggestive congenital myopathy, which was the step 2 and 3 in our approach, hypotonia and weakness and hyperreflexia. Facial weakness, particularly involving the lower face and the mouth, the jaw drops down. Dented upper lip. So as we keep on going up in the face, the weakness usually tends to become less and less pronounced. Weakness is present in the lower face and is out of proportion to any process it is present. There is some amount of dysmorphism, but that dysmorphism actually fits into the gambit of myopathic faces in the form of long face, a dolichocephalic skull, a high arched palate. Many of the varieties have ophthalmoparesis and ptosis, but they may not be present in the neonate. They may develop over the next months to years, and some may have bulbar weakness as well. And the features which are against congenital myopathy are, if the reflexes are, at times, some of the books even say that if the reflexes are elicitable in neonate, then also you should start thinking of an alternative diagnosis. A dysmorphism which does not fit into the gambit of a myopathic face, tongue fasciculations, elevated lactates, elevated CPK, rapid deterioration, and marked distal laxity. All these things suggest that possibly they're not dealing with congenital myopathy. Now, these are the clues within the congenital myopathy, what particular protein or what particular gene may be involved. Again, it's a slightly intimidating table, but the purpose of this illustration is that we have to remember that we have to look for facial weakness, we have to look for ophthalmoplegia, we have to look for ptosis, we have to look for whether myopathic face is present or not, whether bulbar weakness is present or not. If the kid has facial weakness, then within the congenital myopathy, it is more likely to be a nemaline or a centronuclear, whereas the other DDs are myotonic dystrophy or congenital myasthenia syndrome. If ophthalmoplegia is present, then it's more likely to be a ryanodine or any other type of centronuclear myopathy. Ptosis again goes more in favor of a ryanodine receptor disease or a central core disease. Myopathic faces can occur with any of them, but more common with nemaline and centronuclear myopathy. And bulbar weakness again with nemaline and centronuclear myopathy. So weakness of the face, especially of the lower part, goes more in favor of a nemaline myopathy or a ryanodine receptor-related myopathy. Severe respiratory involvement at birth again goes more in favor of nemaline and ryanodine receptor myopathy. These two are the most severe forms of myopathy. If there's a predominantly axial hypotonia, so face was mainly nemaline. The more, and maybe to some extent centronuclear myopathy. If we move away from face, we come to the axial skeleton, that is the neck and the spine, more commonly associated with ryanodine and selenoprotein-related myopathy. And if the hypotonia is present, severe hypotonia is present right at the time of birth, difficulty in sucking, swallowing, then it is more likely to be again nemaline or ryanodine receptor myopathy. Orthopedic deformities, we said contractures are less common, but if contractures are present, then we start thinking of ryanodine. That is the first differential diagnosis that should come to your mind if contractures are present. Hip dislocation with hypotonia, it is ryanodine receptor related problem unless proven otherwise. If the child presents with arthrogryposis or with fetal akinesia, it is possibly an intrauterine onset with nemaline or severe ryanodine receptor myopathy. So, just to summarize this particular table, which is spread out over 3 slides, is if it is a severe form of disease which has its onset at birth or within 1 or 2 months after birth, think of nemaline-related myopathy or ryanodine receptor-related myopathy, the severe form. If it involves the face or the lower part of the face, especially along with breathing difficulties and swallowing difficulties, nemaline should be on top of the cards, whereas if it is more prominent in the axial skeleton and has contractures along with it, it's more likely to be ryanodine receptor-related myopathy. In an older child, the problems are slightly different. Many of these kids present with scoliosis and rigid spine, and the differential diagnosis in such a setting would be selenoprotein-related myopathy or ryanodine receptor-related myopathy. Cardiomyopathy is more common with actin alpha related myopathy, and malignant hyperthermia is basically the hallmark of ryanodine receptor-related myopathy. And respiratory involvement and axial involvement, which is out of proportion to skeletal muscle weakness, is, as a thumb rule, it is selenoprotein-related myopathy unless proven otherwise. These kids continue to walk, but by about 8 to 9 years of age, they go on to BiPAP, initially night BiPAP, and later on they require continuous ventilation. So coming back to where we started from, that the diagnostic chart. So this is a diagnostic chart that we try to modify slightly, that the patient comes and don't do away with the clinical features. Try to phenotype the patient as much as possible. We laid down a couple of steps, whether it's a central or peripheral hypotonia, which part of peripheral nervous system is involved, and within the muscle, whether it's myopathy, dystrophy, dystonic, based on family history, order some ancillary tests, and then go for exome sequencing. And first do the exome sequencing and then sequence the candidate gene and check for the parents as well. Where role of biopsy in all this. Now, biopsy, honestly, we have not been performing a lot of biopsies. And in this particular diagnostic chart, biopsy would be required if there's a diagnostic uncertainty, or we have found a variant where the phenotype is not exactly matching, and still we want to prove pathogenicity. In that case, you can go and do a muscle pathology or a muscle biopsy and check the protein expression, protein abnormalities. Among the ancillary tests, one of the first tests that is commonly ordered is CPK. And if you deal with a child with hypotonia, a lot of times LFTs are usually ordered liver function test. And if you find elevated transaminases, immediately think of ordering a CPK almost parallel to it. So CPKs in congenital myopathies are usually about 200 to 300. As this cartoon over here shows that in most of the congenital myopathies, except for selenoprotein related, they usually stay below about 500 also. So if you find a CPK which is more than 1,000, we are definitely not dealing with congenital myopathy. EMG, a lot of times it is difficult to perform EMG in an infant, but if one ends up performing, you find a myopathic pattern. What is being used more and more is MRI of the muscles, and this was a paper which got published, I think, about 4 to 5 years back, where they looked at the muscle MRI of the lower limbs, and they came up with this algorithm that if the proximal involvement of the lower limbs is more than the distal, that is, thigh involvement is more, and then you look at whether in the calf or whether in the leg it is the gastrocnemius or soleus is more involved or tibialis inferior. Based on this, they've given the algorithm whether it's a selenoprotein related or ryanodine receptor related mutation. This is still in a nascent stage, but it's definitely exciting if we can just on the basis of MRI and predict which all genes to sequence, and if we can narrow down our genetic workup on the basis of MRI. So this is something to watch out for in the coming years. And finally, it is after doing all this, when you're fitted in all other blocks, this should be the final block where one should order next generation sequencing. And it is always better to order clinical exome, which is actually a targeted exome sequencing rather than whole exome, and then determine the pathogenicity of the same. I will quickly go through some of the salient myopathies. One of them is Nemaline, and the two main causes of Nemaline myopathy is Nebulin and ACTA1A gene mutation. And there's a wide range of severity for each of these causes. It can vary from severe weakness, right, time of birth, and even fetal akinesia, going all the way till mild weakness in adulthood. But again, as I said earlier also, the predominant feature is the facial weakness in these children with Nemaline myopathy. And and within that, I said it can be Nebulin involvement or actin involvement, and Nebulin involvement leads to congenital hypertonia, neck and facial weakness, scoliosis, and if we can support them for the first 1 or 2 years, they finally end up walking. They develop walking with support at least. And those with actin usually have a more severe phenotype, and they are the first ones to develop a respiratory failure. So if a newborn with facial weakness and has a normal CPK and goes on to develop respiratory failure, then he's more likely to have an actin-related Nemaline myopathy rather than Nebulin-related. And alpha-tropomyosin is the third protein which can lead to Nemaline myopathy as well as to congenital fiber type disproportion, and they usually go early onto respiratory support. And similarly with the beta-tropomyosin, they usually end up developing contractures. Often many of them are born with arthrogryposis. Ryanodine receptor-related myopathies are important because A, it forms a large chunk and can have multiple pathological features, and B, because it can lead to a potentially preventable complication, which is malignant hyperthermia if we are not cautious about it. And when to suspect ryanodine receptor-related myopathy is if the kid has congenital dislocation of hips with hypertonia, if there is facial weakness along with ptosis and ophthalmoplegia, and if it is more of an axial phenotype involving the neck muscles and the spine muscles rather than the limb muscles, then one has to think of an gene receptor related myopathy. The central core disease, which is again a manifestation of ianodine receptor related myopathy, again similar orthopedic problems of hip dislocation, spinal problems, foot deformities, and multiple mini core disease, again a manifestation of ianodine as well as selenoprotein related myopathy. This somehow, we have seen a couple of cases in the past 2 to 3 years where we picked up at least two kids with selenoprotein and related disorders. And the hallmark was that these kids presented to us after 10 years of age. In fact, one of them presented to the neurophysician and was thereafter sent to us. And they had mild weakness, scoliosis. They were ambulatory even at 14 and 15 years of age, but they went on to respiratory support by about 8 to 10 years of age. So it is important to understand the phenotype, because if you support them well, then you're kind of ensuring them a relatively more comfortable life. And dynamic 2 is the main cause of dominant centronuclear myopathy. Now, this is one of those rare causes of autosomal dominant myopathy. That's why I highlighted. And X-linked myotubular myopathy, we just have seen in a couple of cases in which these children do not survive for more than 1 year, and they have a universally fatal outcome. I'll conclude with this slide that where I started from, the clinical acumen still continues to be the most powerful force in the diagnostic universe. We have a lot of times deviated from identifying the clinical phenotype and have jumped onto ordering the exome. It is disturbing, and metaphysically as well as physically to the patient. And it is important to understand the clinical phenotype for these children, central versus peripheral. Within the peripheral, what are the features such as your muscle, neuromuscle, nerve, and anterior horn cell, and within the muscle, differentiating myopathy with muscular dystrophy. And within the congenital myopathy, understanding whether there is facial involvement or not, there is ophthalmoplegia, ptosis, whether there is axial involvement more than the limb involvement or vice versa. And finally, combining it with the genetics, and the two have to coexist in the current scenario. And I'll end with this flowchart that identify the clinical features, phenotype the patient, use the ancillary tests wisely, use CPK, use EMG NCS, use MRI of the muscles, and then go on to exome sequencing and confirming. I have ended, and if there are any questions, the easier ones can be asked to me, and the tougher ones can be kept for Dr. Prashant.
Thank you so much, sir, for such a lucid presentation of a difficult topic. Any questions from the audience? I think it's too clear to them to ask anything. So, Dr. Inder, should we move to next speaker?
Yes, ma'am.
Thank you very much.
Thank you, sir. Thank you. So our next speaker is Dr. Prashant Johari. Dr. Prashant has done his DM from PGI Chandigarh, and currently he is Associate Professor in the Division of Child Neurology, Department of Pediatrics, AIIMS, New Delhi. He has over 50 publications in his credit, and
Hello. Hello, Inder sir.
Yes, Nityaji.
Your slides are not visible, sir.
Hello.
Yeah, slides are not visible. Once again, you share it.
Inder sir.
आंख हो गई शायद कुछ तो हो रहा है पता नहीं देखो देखो इसमें क्या है
No issues.
Everybody, please mute yourself except the presenter.
Inder sir, you can try. You can put yourself.
We can go on, ma'am. Has already introduced Prasant sir.
Okay. So,
Ma'am, I'll need your permission to start then.
Sure, Dr. Prashant, please go ahead.
Thank you, ma'am, and thank you to all the organizers for calling me in. So I'll be moving to the next part of the session, which is about congenital muscular dystrophy. So let me share my slides. Someone please confirm if the slides are visible.
it's visible, sir. Perfectly
Okay.
all right.
Okay, thank you. So good evening, everyone. So thank you, Dr. Vishal, for covering the topic well and I would say within time. So I'll be talking about congenital muscular dystrophy, which is almost similar to congenital myopathies in multiple ways, in which, in fact, Dr. Vishal has already told you. But I'll start by saying that both these disorders are very important disorders because not much of knowledge is available with treating physicians, and then it ends up in lack of diagnosis. There's a significant time lag, and then we don't have the exact genetic etiology known to us because of the involved genetic complexities and the phenotypic variability. It is definitely a complex topic. So in the next 30 minutes, what is my plan is to actually give you a simplified pattern recognition so that you are able to build up an initial approach. Then definitely there is a lot of overlap and you would need a lot of help from the geneticist or maybe a little bit of interpretation of the genetic reports to move further. So I'll begin where Dr. Vishal actually started. I'll start also in the same manner because the topic has a lot of overlaps. So there would be some overlap in what we say. But believe me, all these things would be important for your initial concept building. So we now know that like congenital myopathies, congenital muscular dystrophies are also a group of heterogeneous disorders. They have distinct genes that are getting affected and the phenotype is very variable. So in itself, it is quite variable and sorry. Okay. So am I audible now?
Audible, sir. You are perfectly all right.
Okay. So there is definitely a lot of overlap that happens. Both of them are actually presenting in early infancy, and the primary affection is, or the hallmark would be significant muscle weakness. So we need to have our fundamentals right as to what is the actual distinction between the two then. So with this so much of genetic and phenotypic variability, still we need to understand that the basic difference between these two is, wait, Mr. Nitya, the slides are not moving.
Oh, actually, someone is requested not to annotate. Don't throw your finger on the mobile. Someone probably from the participant is throwing your finger on mobile. So it will. So please stop annotation. That will bring the annotation request. And if it is coming, Prashant sir, you can drag it down. And participants are not requested not to annotate.
Okay, thank you. Thank you for the help. So the basic difference is actually that a congenital muscular dystrophy will have dystrophic features on biopsy. So what is as a clinicians also we need to have a basic understanding about this. So these are the two slides. The one on the left is from a child with a collagen 6 muscular dystrophy, and on one on the right is actually a slide of a child with Duchenne muscular dystrophy. So in both these dystrophies, what we'll see, or in all forms of dystrophy, what you'll see is that both necrotic, the small fibers, and large fibers regenerate, which are regenerating fibers, would be seen in the same slide. And as look at the blue arrows, these they show that these are areas of fibrofatty infiltration. So whenever you get fibrofatty infiltration with necrotic and large fibers, or regenerating and degenerating fibers together, this shows that definitely there's a dystrophic process that is going on. So this is one thing which is distinct or different from a myopathy. And the other fundamental difference that the previous speaker has already informed you is in the proteins that are getting affected in these disorders. So congenital myopathy is what is happening is that the basic excitation contraction coupling is getting affected. So we'll have affection of myosin, titin, actin, myotillin. While in a muscular dystrophy, what is happening is that the contractile proteins are all preserved, but the extracellular matrix, which is supporting the sarcolemma, gets affected. So you will have affection of collagen 6, you will have affection of dystroglycan complex, you will have affection of the Golgi apparatus with fucotin and other proteins which will lead to dystroglycanopathies. So these are the proteins which get affected when you have a muscular dystrophy. So the crux of the topic is now actually is to bring up a simplified pattern recognition so that we are able to identify a phenotypic subtyping. Now, Dr. Vishal has already told you that this is an era of next generation sequencing with almost it is now bedside available. But the issue is that with more and more genes coming every day with a lot of variability, genotypic heterogeneity is there. So you have to have some basic clinical suspicion. Otherwise, it will just become a fishing expedition if you go ahead with what Dr. Vishal showed you, that from family history and little bit of clinical complaints, you go straight forward to getting a genetic testing done. So in the next few minutes, I will just be discussing on the clinical phenotypes which will be relevant for bedside diagnosis for us as clinicians. So congenital muscular dystrophy, yes, we know that it is a rare disease. The data from India is not available, at least in European population. The prevalence is 1 in 1 lakh people. What we know, however, that globally as well as in India, collagen 6 deficiencies and myrosin deficient CMDs are the most common phenotypes that we see. And yes, the cardinal feature is progressive skeletal weakness with hypotonia, and CPK is actually can be mildly to significantly elevated. So it is variable. So from our center under our chief, Dr. Shefali, we had done a retrospective analysis, which in fact Dr. Panda presented at an international conference. So this is a retrospective data of 5 years where we found that among the 961 children with hereditary muscle disorders, congenital muscular dystrophies were there in 36 patients. And what we again saw that myrosinopathy, collagen 6 muscular dystrophies were the two common ones that we saw. So the $1 million question would be again to for a clinician is to when to suspect congenital muscular dystrophy. Now, Vishal has already told you that how do you actually differentiate between a central cause and a peripheral cause. So I'm taking it that this is the basic understanding is already there. So in any floppy child or a child with some degree of paralysis or paralytic hypotonia or a weak hypotonia, if you find that there are very early contractures that are present, if you find that there is an associated congenital hip dislocation is there, or you find that on top of the paralytic weakness, there is an add-on global delay with or without upper motor neuron signs, that is a mixed hypotonia-like picture is there, or there is dysmorphism, there is MRI evidence of CNS malformation. So if you have any of these settings, then it should come into your mind that probably you are dealing with some kind of a congenital muscular dystrophy. So if I have to use a single sentence for this presentation, then I would say that if you have a mixed presentation where you find a lot of peripheral weakness along with some UMN or dysmorphism or some sort of a global decline or a cognitive decline, then this is the clear hallmark where you should start suspecting congenital muscular dystrophy. But having said that, this is not always true. There would be a subset depending upon the subtype, which will have which will be intellectually preserved. In fact, can be ambulatory. So these kids would be presenting late and has to be differentiated from LGMDs. Now, this Dr. Vishal has told you that if you have prominent ophthalmoplegia, significant facial weakness, respiratory depression at birth, then CMD should not be your top differential. You should think of congenital myopathies, and along with that, congenital myasthenic syndromes can also be a good possibility. So talking about the subtypes, yes, the spectrum is expanding, and despite of knowing so many genes, the current mutation detection rate for CMDs ranges from 20 to 46%. So you cannot just go ahead with a genome first approach. So that is why we are trying to have a pattern based approach. But yes, believe me, there would be a subset where this might not work, and you have to go ahead with a genome first approach maybe. But for a basic concept building, this is what every clinician should be aware, how to proceed with pattern recognition of various clinical subtypes of congenital muscular dystrophies. So broadly, these are three major forms of dystrophies that we see. One is collagenopathy, which is because of collagen 6 related disorders. The disorders under which will be Ullrich muscular dystrophy, and on the milder spectrum of it would be Bethlem's myopathy. The other one is a myrosinopathy, that is a myrosin deficient CMD, also known as laminin alpha 2 CMD. And the third big group is of dystroglycanopathy, which in itself has a number of syndromic CMDs known as the Walker-Warburg syndrome, muscle eye brain disease, and Fukuyama CMD. Apart from these three, there are two rare which are now actually picking up, and we have seen a few cases. I'll show you them. So these are a rigid spine congenital muscular dystrophy secondary to SEPN1 deficiency, and laminopathy, which is LMNE CMD. So I'll be showing you cases so that you have developed, you see and observe what sort of a presentation is there, and we try to draw some clinical conclusions of when to consider a specific subtype just based on clinical findings. So now in front of you, there is a girl who is a 4-year-old child presented to us with motor delay and hypotonia. There was knee contractures, and as you can see in the picture provided, that there is distal hyperlaxity is there. The child also had some finger flexion contractures. Now the child on the right, I'm playing the video for you. This child is a 2.5-year-old boy who also had a similar complaint. Now you can see the examiner is showing you how hyperflexible the distal joints are. And then you need to see and appreciate, then only you would know. But these kids have very typical velvety hands and toes, or the palms and soles feel very soft and velvety. So whenever you have such a presentation where there is an intellectually preserved child who has a paralytic progressive weakness, and there is distal hyperlaxity along with a proximal contracture with velvety soft hands. So this is a picture that suggests that probably you are dealing with a collagenopathy, that is collagen 6 related muscular dystrophy. So what is this? So this is because of collagen 6, which is there in the muscle extracellular matrix as well as the dermis. It definitely has a variable phenotype depending upon the degree of affection of the gene. So it can, and on the severe-most, there is a Ullrich congenital muscular dystrophy, and in a milder form, it can present like a myopathy, which is known as Bethlem myopathy, and there is an intermediate form as well. So the key cardinal features that you are going to see, or I'm reiterating them, is that you will have distal joint hypermobility, proximal contractures, especially of elbow, knee, and then finger flexors. There is a prominent calcaneae, congenital hip dislocation can be there. There can be early kyphoscoliosis, and these kids will have a progressive respiratory insufficiency as the age progresses. And this will have a disproportionate affection of diaphragm. In the skin also, you will find some characteristic features. As I told you, soft velvety skin would be there. There would be tendency for keloid formation or atrophic scars. There would be hyperkeratosis pilaris. Along with this, as I told you, that these kids would be cognitively preserved, at times advanced for age. The CPK, though it is a dystrophy, but still the CPK is maybe normal or mildly elevated. The child that I showed you had a CPK of 340 international units per liter, and they will not ambulate, or if they ambulate, then they would lose it by late first or the early second decade. So this is the hallmark of this entity. How we diagnose this? So the gold standard is now a molecular testing where we detect collagen 6 mutation. So now in this disease, we have seen that almost all the cases actually have a mutation in one of the three collagen genes, that is collagen 6A1, A2, and A3. Now, so the child the girl that I showed you on the left had carried a collagen 6A1 mutation, which was pathogenic. So we had a genetic diagnosis in that case. We suspected Ullrich's, so the phenotype was matching with the genotype that we obtained. However, the child on the right was not affording, and we went ahead with muscle biopsy and immunohistochemistry. So on H&E stain, we saw signs of dystrophy, which are fiber size variation and fibrofatty infiltration. And the immunohistochemistry showed absent collagen 6 stain. So the slide on the left shows that there is absence of collagen 6 stain in the muscle, while on the right, this is showing the normal collagen stain that is there. So this is how by simple immunohistochemistry, we were able to establish a diagnosis even without going ahead with a genetic testing. Now we know that collagen is also present in skin. So from our institute, there was a study we published. In fact, my colleague, Dr. Bishru, published with Professor Shefali. In fact, it was done before I joined actually. So we had shown that, in fact, by just getting a simple skin biopsy and demonstrating absence of collagen 6, you can actually achieve the diagnosis. So it will be a less invasive procedure, but yes, it has to be proved in bigger trials, then only we can actually take it into a service mode. Other supportive finding is that in these kids, sometimes what happen is that in the rectus femoris muscle, there is a central cloud formation which is visible even on ultrasound, and if you do an MRI, then it is quite visible. Now this ultrasound is an image of the girl that was genetically proven collagen 6 disease with a central cloud formation in rectus femoris. Now this is an image which has been taken from the internet, which shows that in the rectus femoris there is a central cloud formation that is occurring. Now you can appreciate here that in this sartorius muscle and this gracilis muscle, they are actually spared. So if there's hyperintensity in other muscles, not in these two. So you can take this information also that sartorius and gracilis are less affected or spared in children with collagenopathy. And there is a central cloud formation that is there in rectus femoris. So these are the additional supporting finds if you go ahead and get an MRI or an ultrasound of the muscle done. So moving to the second case scenario. So now this is about a 2-year-old floppy infant. The child had motor predominant developmental delay. It was actually referred to us with a provisional diagnosis of hypotonic cerebral palsy. The child could only sit transiently with support. There was generalized hypotonia, there was ankle contractures, and DTS were not elicitable. So it didn't appear to us that the child had got a central hypotonia. So we went ahead and did a CPK total, and which was elevated almost more than 5 times. So this gave us a thought that probably we are dealing with some kind of a congenital muscular dystrophy. So in this setting, we went ahead and got an MRI done. So this MRI of the kid showed that there were deep white matter hyperintensities which were diffusely present. Let me use a marker. Okay. So in this MRI pic, you can see that the white matter hyperintensity is there, which is primarily in the deep white matter. and there is a sparing of the internal capsule and the corpus callosum. So in this sagittal section, we see that the cerebellum and the pons and vermis are all okay. So this white matter hyperintensity giving a picture of a leukodystrophy in a child with paralytic hypotonia actually suggests that probably you are dealing with a myrosin deficient congenital muscular dystrophy. So this is because of deficiency in the laminin alpha 2 protein, which is another name of myrosin and is caused by a mutation in the LAMA2 gene, which encodes for this. Now, depending upon the degree of affection, that is complete absence or partial absence of laminin or myrosin, you will have non-ambulant or an ambulant form of this disease. Now, in muscle biopsy or immunohistochemistry, the muscle will take up stains for other proteins like dysferlin, sarcoglycan, dystrophin. However, it will not take up stain for myrosin, so you can simply establish a diagnosis here. But yes, you will not be able to pinpoint the genetic abnormality that has led to this. But this is again a simple way of getting to the final diagnosis. The key features that are there in myrosin deficient CMD is that they have significant hypotonia. There is weakness of extremities in an early age. There are contractures of hand and feet, giving to a arthrogryposis-like picture. There is mild facial weakness and ultimately later on jaw contractures, which disrupt feeding and lead to failure to thrive. The CPK is typically elevated more than 5 times, but not always. Seizures are common and seen in up to 30% cases. But despite of this white matter abnormalities and seizures in quite a significant proportion, the intelligence stays preserved or only mildly affected. Later on in childhood, at times peripheral neuropathy is observed, but it is of not much of a clinical meaning. MRI gives us the best clue to get to the diagnosis. So if any child with a normal intelligence with paralytic hypotonia or mildly or elevated CPK, if you find these form abnormalities that the white matter appears hyperintense on T2 flare, and this abnormality actually takes time to develop and is seen mostly after 6 months of age. So if you get an MRI before that, you might not be able to appreciate that. And as I told you, there is a sparing of the internal capsule and corpus callosum. There can be some subcortical cyst, and in 5% of them, there can be malformations also, which are primarily the occipital cortical dysgenesis or cerebellar hypoplasia. Now, unlike leukodystrophies, these MRI changes do not progress. So you don't need to repeat MRI and see for disease progression. Now, this image that is there is from another child which was 2-year-old. The image was provided to me by our Professor Dr. Atin from radiology. So this child actually, the diagnosis came more when we got an MRI done. Post MRI, we retrospectively saw that possibly we have missed the clinical findings of a possible CMD. So this is how MRI can be very helpful in these subtype of CMD. Coming to the third clinical scenario, so here we have a 6-year-old girl. She had delayed attainment of milestones. There was intellectual disability. She had generalized seizures from 1 year of age. There was severe myopia for which glasses were provided by the ophthalmologist. The weakness was proximal more than distal. There was hypotonia, hyporeflexia, ankle contractures. And because of this, a mixed presentation of paralytic weakness with intellectual disability and seizure, we thought that possibly a CMD can be a differential as the problem started very early in life itself. So CPK was done, which was elevated 1410 international units per liter, and we went ahead with an MRI brain. Now here in this child, unlike the previous case, what we saw was the significantly malformed brain. So you can see that there are decreased convolutions that are there, a simplified pattern is there, there is white matter hyperintensity is there, and there are some cerebellar cysts which are also there. So this classically fits into a type 2 lesion Kifli or a cobblestone variant. So with this lesion Kifli like cerebral malformation with a mixed weakness with intellectual disability, the possibility that should come in our mind is that we are dealing with some sort of a dystroglycanopathy. So muscle biopsy was done and IHC for dystroglycan showed that there was absent staining for alpha dystroglycan. So it established the diagnosis and the child was considered as an alpha dystroglycanopathy. And because there was significant brain, eye in form of high myopia and muscle affection, so the diagnosis was given as a muscle eye brain disease. Now this alpha dystroglycanopathy is a wide variety. Now this has got multiple genes that are getting implicated, and the common ones are FKRP, POMT1, 2, and POMGNT1. So these are the 4 common genes which get affected, but now and recently we have seen a lot more genes that are getting implicated here. So the spectrum is wide. So on the severest spectrum lies the Walker-Warburg syndrome, where we have a prenatal onset severe weakness which precludes ambulation. The child has significant major CNS structural malformations and may succumb by a year or 2. Muscle eye brain disease is less severe than this. Still, the congenital weakness is there and walking is always rare. Ocular involvement is common. Fukuyama comes with mild weakness with intellectual disability and epilepsy. And on the mildest spectrum is an LGMD phenotype, which can have a DMD or a BMD-like severity. So the cardinal features here are in the musculoskeletal system, in CNS, and in the ocular system. The musculoskeletal system, as I've already told you, that the weakness would be variable depending upon on which spectrum or which gene is getting affected. There would be muscle hypertrophy and pseudohypertrophy. There could be scapular winging, Trendelenburg gait, but this would be seen only if the child attains ambulation or progresses in age. Then there could be occasionally a myositis like rapid decline, which is also seen in these patients. And these are partially responsive to steroids as well. Now, dilated cardiomyopathy is also a feature of this CMD, which is not present in others, but which is seen specifically with these 3 mutations. In CNS, we'll see intellectual disability, epilepsy in significant proportion. We'll see cobblestone lesion cephali, or they can be a focal pachygyria, polymicrogyria complex. In the infratentorial region, we'll see a midbrain hypoplasia or a pontocerebellar hypoplasia with cerebellar cysts. There would be white matter changes, which, unlike myrosin deficient CMD, may regress with age. And these white matter changes are not seen in those who have preserved intelligence. Now, this association was not there in myrosin deficient CMD. So the degree of white matter changes actually is not related with the cognition in myrosin deficient CMD, but in alpha dystrophic glycans, the children who are more disabled cognitively have more significant MRI features. So these are the ways by which we can differentiate between these two. And in eyes, you can have optic atrophy, myopia, retinal detachment, and nystagmus. So these images, have been taken from the internet to show you that how these cerebellar cyst clearly looks like. And then there's a pontine cleft that is there in the midline. And this is a polymicrogyric brain. So these are the additional features that you need to look at an MRI, and these are quite suggestive of an underlying CMD, dystroglycanopathy. Now the diagnosis can again be made on biopsy with an IHC that shows that anti-alpha dystroglycan antibodies are not taken up in that slide, and it has been a simple manner. But because there are multiple genes that are getting affected, so knowing these would be important for future planning of the further pregnancy, and maybe for future newer therapies that might come in. So these days we are actually, the genetic testing has become the preferred diagnostic modality. So this is another child that we had. It was a 1-year-old affect with some mild facial dysmorphism. The CPK was elevated, and a possibility of a congenital muscular dystrophy was thought in. We didn't get an MRI brain done by that time, and the mother was again pregnant. So we went ahead with a genetic testing itself, and that showed that the child had a compound heterozygous mutation in the POMT1 gene, which is suggestive of an alpha dystroglycanopathy. Now, we were not able to characterize him into any of the specific syndromic diagnosis, but then this is also quite possible. Coming to the fourth scenario, now this is a 15-year-old girl. The child has came with inability to hold neck and was achieving the other milestones normally. The child gained ambulation at an appropriate age. She was alert, interactive, and there was generalized hypotonia to look at. Now, please look at the video. So the child was ambulant, but you can see that what the degree of neck weakness which is there. So there is a significant neck weakness, and both the flexor and extensor muscles are affected, and it's giving a dropped head-like posture. The ambulation was quite normal. The CPK was normal, and on examination, we saw that the spine appeared a bit stiff to us. There was no curvature of the spine that could be appreciated. So whenever you have such a phenotype where you have an intellectually preserved child with almost mild or no weakness, but a prominent neck extensor and flexor weakness, so you should think of a possibility of an rigid spine related CMD, and which is primarily because of SEPN1 gene defect. Now, these kids actually later on develop a lot of respiratory insufficiencies. As Dr. Vishal told you that he saw a kid who came to him in the second decade of life. So by that time, these would continue to ambulate, but soon will start requiring home ventilation or respiratory support. So we went ahead in this child with genetic, because we were able to pinpoint the underlying genetic etiology. We specifically asked for SEPN1 gene, and we found that the child had got a gene variation in that. And as the phenotype was very sure, so we took this uncertain significance as a likely pathogenic gene mutation. So rigid spine syndrome, as most commonly, is because of SEPN1 gene. As I told you, poor and delayed head control is the most common presenting feature. As the child progresses in age, especially in early infancy, in later infancy itself, there is significant neck flexor and extensor weakness, which gives a characteristic dropped head appearance. There is a relative atrophy of the inner thigh muscles and mild facial weakness also, which can be appreciated in later childhood. Joint contractures are characteristically absent in these patients. However, there is a significant spinal stiffness that leads to this name of rigid spine syndrome, which is appreciated within the initial 5 years of age. As the age progresses, late respiratory insufficiency sets in when the child is still ambulant. So on muscle MRI, we see that there is sparing of the rectus femoris, the sartorius gets more affected, and there's a soleus muscle is least affected, and this way it can suggest a possibility of SEPN1 gene defect over some other differentials. So the other differentials are an Emery-Dreifuss like muscular dystrophy, Pompe's or collagen 6, which can also come with rigid spine, but all of them have prominent joint contractures and raised CPK, which is able to differentiate it from SEPN1. The LMNA related muscular dystrophy, which is because of a laminopathy, also will have a high CPK. There would be a cardiac involvement and a scapuloperoneal weakness, by which we can actually differentiate this presentation from SEPN1. So clinically, you can be very particular about this entity if you are aware of all these phenotypes that can be possible. Now, coming to the last scenario, then this is a child who came to us at 13 years of age, had an early onset motor weakness. There was some ophthalmoparesis. Then there were contractures which set in by around 5 to 6 years of age. On examination, there was ptosis, facial weakness, high arched palate. There was contractures in the bilateral elbow, scoliosis, and wrist. This was visible in the video also. The bilateral TA contractures and the contractures at the elbow. There was no scapular winging. And in the lower limbs, what we saw that a typical goers was not coming, but there was a thinning of the lower legs and a more peroneal type of a weakness was there. So possibly this child had got a proximal shoulder weakness, and in the lower limb, it was a peroneal distribution. So a scapuloperoneal sort of a weakness was there. The CPK was significantly elevated. The cardiac was normal, but but such a presentation suggests an Emery-Dufus sort of a phenotype. So if when you have an Emery-Dufus sort of a phenotype which presents very early or starts very early, then a possibility of a laminopathy or a lamina associated congenital muscular dystrophy is to be considered. So we went ahead with the genetic testing and we found that the child had an LMNA associated gene variation, which was likely pathogenic. Now, this is the last slide I want to show you. So this is the crux of whatever I have talked till now. I will not repeat it. You can go ahead. So this just gives you the clinical features along with major investigations, which will help you to have these patterns in your mind so that you can start with a correct diagnostic approach. Thank you.
Thank you so much for an excellent presentation. I think there is a couple of questions for you in the chat box. Yes, what is the difference in brain in MCD1 with partial or complete merosin deficiency? And are MRI changes resolved in later age?
Ma'am, can you please again repeat the question, please, ma'am?
What is the difference in the MRI brain in MCD1 with partial or complete merosin deficiency? And are changes resolved in later age?
Okay, so I actually gave the answer for this question in the talk itself. So these changes actually do not progress; they stay the same. So this would stay the same. You repeat the MRI at 1 year or 5 years, this is going to stay the same, and there's no difference or there's no significant difference between a partial and a complete deficiency as far as the MRI picture or a white matter hyperintensities are concerned. So this stays the same. The difference only is in the paralytic hypotonia or weakness that these children will have.
Okay, Dr. Prashant. Any other question from the audience? Then thank you so much, Dr. Prashant. Now, Dr. Inder.
Thank you, ma'am. We can end the session now. Thank you, Prashant sir. Thank you, Vishal sir. And thank you, Sriparna ma'am, for today's session.
Thank you so much.
Thank you, ma'am. Thank you. Thank you, everyone.
Thank you, Vishal sir.
Thank you.
Thank you, Sriparna ma'am, for conducting a chair session. And both the presentations were extremely to the point presentations, and they were quite illustrated with videos, and really they were quite to the clinicians, less to the pediatricians, and to the pediatric neurologist. Tomorrow we'll be taking a session on muscular dystrophy, sports limb muscular dystrophy. Same time from 7 p.m. to 8 p.m. I wish to everybody request everybody to join the meeting also. Thank you, everybody.
Pratik sir, tomorrow's link will be different from today's, yeah? It will be different link.
Yeah, tomorrow the link will be different, and the link has been already said, and anybody if is not said, we will be again
tomorrow morning.
Tomorrow morning we'll be sharing. Okay. So I request everybody to share it in the maximum to their known pediatricians and anybody who is interested, so that maximum people can this meeting. Thank you.